Today we welcome Dr. David Hamer, Professor of Global Health and Medicine at the Boston University School of Public Health, Chobanian Avedisian School of Medicine. Dr. Hamer is a board-certified specialist in infectious diseases with a particular interest in tropical infectious diseases. He has over 25 years' experience in infectious disease research with a concentration in neonatal and child survival. Today's webinar will increase your understanding of infectious gastroenteritis and diagnostic testing. You'll have opportunities to ask questions throughout the program, but we'll hold your questions till the end. To participate, just use the chat box of your GoToWebinar control panel, and you can do this at any time. For now, I'll hand the mic over to Dr. Hamer to tell us more about what's ahead. Welcome, Dr. Hamer.
Thank you very much for giving me the opportunity to present to you. So I'm going to start, this is an overview of the agenda. I'm going to start talking a little bit about sort of some basic terminology for infectious gastroenteritis, primarily focused on diarrheal disease, a little bit about the disease in terms of transmission and sort of modes of transmission, in particular risk factors. We'll talk a little bit about etiology, so the cause of the disease and some major pathogens and how these differ. Then we'll discuss diagnostic testing methods, and then wrap up talking about the benefits, but also a little bit about the limitations of molecular testing. Next, please. So first, some basic terminology. So foodborne illness is basically disease acquired through eating or drinking contaminated food. And much, diarrhea transmission, as we'll talk about more, is through vehicles. That's an inanimate object that can convey a pathogen. That can be a food, but it also can be water. It can be sort of contaminated surfaces. Toxin-mediated disease, this is actually the cause of many forms of, especially bacterial diarrhea. Bacteria such as enterotoxigenic E. coli, for example, will secrete a toxin that changes the normal sort of level of absorption or secretion at the level of the intestine, and that can lead to cramping and watery diarrhea. But also toxins can form if bacteria are present in food and the bacteria start to multiply, they may produce a toxin that the toxin causes the manifestations. And that's when we talk about food poisoning, that usually refers to a toxin that's developed in the food because of bacteria. And just to comment on these two photos, on the bottom left is a job site where I help provide medical care near Takoradi, Ghana, so Western Ghana, almost on the border of Cote d'Ivoire. We kept having an outbreak of diarrheal disease on all the workers at the job site. They were constructing a power plant, and we finally realized that the local women from the villages were bringing in food that they made in the morning, and they didn't really have good facilities to heat it up. They had no place to wash their hands. They didn't have access to clean water, and basically they were serving contaminated food to all of our employees. And so we moved them to a better place, and then we gave them access to better water, and our diarrheal disease rates plummeted. On the right is a street scene from Dhaka, and you can see that there's a gentleman out there, I think he's got coconut milk out in the hot sun. Anything that sits out in the hot sun for hours is going to be really dangerous in terms of potential as a foodborne, as a vehicle for transmission of foodborne disease. Next slide, please. So just a couple basic terms. So diarrhea is basically an abnormal sort of loose stools. Generally, for clinical trial purposes, this is defined as the passage of 3 or more loose or watery bowel movements per day, or more frequent passage than normal for the individual. Invasive disease is disease where there's bacteria or sometimes a parasite such as Entamoeba histolytica that actually invades the mucosa, the lining of the intestine, and that can lead to both an inflammatory diarrhea with pus and a lot of white blood cells, but also bleeding. And then dysentery is really another name for bloody diarrhea. It's really any infection, any intestinal infection that leads to bloody diarrhea. And you know, one of the perils of travel is finding access to good toilets. And this scene on the right is what you typically find in many parts of you know, low-income parts of the world for a toilet. Next, please. So let me say a little bit about the disease itself. So infectious gastroenteritis is basically an infection of either the small, large, or large intestines, or both. And it may be due to severe inflammation, but it also may be toxin mediated. So there's some bacteria that don't cause much inflammation, but they'll cause basically an outpouring of sort of an imbalance in the normal absorption of liquids. So less is absorbed or more is secreted, and that leads to a lot more water in the intestines and a watery diarrhea. There are a variety of different pathogens that can cause this. These range from bacterial to viral or parasitic. There are really very few fungal pathogens that cause diarrhea. And as I mentioned, some pathogens are more likely to release toxins that cause a secretory diarrhea, whereas others will do damage by really attacking the mucosa, although they may also have toxins that can do damage to the mucosa. And that leads to what we call invasive diarrhea, which often is manifested by blood in the bowel movement. Next, please. So these are some of the complications of diarrhea, and the most common and important one is dehydration. And there are ways to classify dehydration based on physical examination, but you can also do it based on weight loss. So more than 5% loss of total body weight is considered moderate diarrhea. And very dangerous situation is when you have more than 10% of weight loss in the context of severe diarrhea. This latter usually requires intravenous hydration, whereas mild to moderate dehydration can be managed with oral rehydration. With the diarrhea, there may be a lot of loss of potassium and bicarbonate, and that can lead to metabolic acidosis and hypokalemia. But also, some of the pathogens lead to a lot of nausea and vomiting, and if you're vomiting a lot, you may lose bicarbonate, and that too can contribute to metabolic acidosis. There are a whole host of other possible complications: muscle cramps, acute tubular necrosis, basically problems, damage to the kidney, and that can lead to diminished urine output. There may be hypoglycemia, a low sodium level in the blood, and this can progress in the context of severe dehydration to shock and death. And one of the clinical signs is skin elasticity. If you pinch your skin and it immediately goes back into position, that's because you're well hydrated. But somebody who's very dehydrated, you pinch the skin, and it may take several seconds for that skin to fold back into a normal position. And that's the result of decreased turgor and greatly decreased hydration status. Next, please. So there's a long history of diarrhea. I mean, honestly, this has been around for millennia, but this is sort of the more recent timeline, and it really, some of this started with the suspicion that viruses, a filtrable substance, were causing diarrhea, but it took many decades before we really were able to identify some of these viruses. Poliovirus, which doesn't really cause diarrhea but is enterically transmitted, was one of the first. In the 60s, there was an outbreak in Norwalk, Ohio, and eventually, they did a lot of basic bacteriology. They looked for parasites, and they finally decided this might be a virus, and they called it the Norwalk virus. Eventually, over time, they were able to identify this using electron microscopy, and then a whole host of families, and it's actually the family of caliciviruses, were identified, and many of them were called Norwalk-like viruses. And finally, around 1990, they changed the name to norovirus. And in the United States and many parts of the world, norovirus is one of the major causes of outbreaks of diarrheal disease. Next, please. So This is a sort of a little bit about pathophysiology of diarrhea, and so it's secretory. So the pathogen, releases a toxin. This leads to either decreased absorption of liquids from the gut or increased secretion. Generally, very little inflammation, and then it leads to a very large amount of watery, relatively large volume stools. Classic example of this is Vibrio cholera, the agent of cholera. Very little inflammation, but just massive watery diarrhea. Enterotoxigenic E. coli does the same. In contrast to that, there are pathogens that lead to much more of an inflammatory response, attacking, invading, and destroying the gut mucosa. And again, they may also be releasing toxins that lead to increased inflammation. And some of them actually can be absorbed into the circulation and lead to complications such as hemolytic uremic syndrome, and that can lead to kidney failure and other complications. The inflammatory pathogens generally present with smaller volume bloody stools, and there is often fever associated with those syndromes. Next, please. So this is a brief description of modes of transmission, and there are sort of several different modes. One is just contamination of food or surfaces with human feces. So basically contamination, and the contamination of food or water may also occur, and there may be environmental complications, and then person-to-person transmission. And there's sort of the 5 F's of transmission. So fomites, which is really contamination of surfaces, food, feces, and fluids. I think there's a 5th too. And so there's sort of different modes of transmission. I think foodborne disease is one of the most common, as is waterborne, but person-to-person can happen with certain pathogens. Certain pathogens that have a very low inoculum, like Shigella, are more readily transmitted person-to-person. The picture in the far right-hand corner is from Dali in Yunnan, China. And I took this because you see in the back there's a restaurant, and they're serving food there, but right in front is the butcher. And so people are working, chopping the meat, and then somebody comes in for a bowl of soup, and they turn around without washing their hands and start serving them the meal, and just amazing cross-contamination. That, unfortunately, is the sort of kind of situation that is high risk for transmission of gastrointestinal pathogens. Next, please. So I'm just going to say a little bit about some of the major causes of infectious diarrhea. And as you can see from this list, there are quite a few. On the bacterial side, salmonella, non-typhoidal salmonella in particular in the United States is one of the major pathogens associated with outbreaks. Shigella is less common. There are 4 species that cause shigellosis, but this can cause an invasive diarrhea where antibiotics are really necessary. Campylobacter jejuni has become one of the most common pathogens in the United States. And then Clostridium difficile, this is much more of a hospital-associated problem in general. Yersinia enterocolitica is pretty rare. Vibrio cholera, fortunately rare in the United States, but it can cause major outbreaks in low-income countries. And then E. coli, there's a whole host of different strains of E. coli. Probably the 2 most important, 2 most common worldwide are enterotoxigenic and enteroaggregative E. coli. But enterohemorrhagic E. coli, E. coli 0157H7, for example, has caused a number of outbreaks in the United States, usually associated with ground beef, but sometimes with other vectors. And that can cause a bloody diarrhea that may be complicated by kidney problems. At the bottom of the list on the bacterial side are 3 different bacteria that produce toxins that leads to food poisoning. So it's really not the bacteria itself, but it's the accumulation of toxin in the food that leads to the illness. These are often characterized by more nausea and vomiting and a little less diarrhea. On the virus side, there are several major viruses, but the top 2 are rotavirus, especially in young children, and then noroviruses, which can attack any population. The other 3 are much less common. On the parasite side, there are a number of different parasites beyond those on the list, but in the United States, Giardia lamblia and Cryptosporidium parvum are probably the two biggest, although we do have Entamoeba histolytica often coming in migrants or people who have traveled to low-income areas of the world. And then Cyclospora, which has actually been implicated in past outbreaks associated with raspberries, but sometimes other vectors, and we see sporadically. And then Cystispora belli, used to be called Isospora belli, is pretty rare and is more common in really low-income settings and immunocompromised patients. So if we can move ahead, I'll talk a little bit about some of these specific pathogens, some of the more common ones. So I've already mentioned a little bit about the history of norovirus. This is extremely easy to transmit. It's very contagious. It's found both in the feces, but also in the emesis, in the vomit of infected individuals. Almost everybody's at risk. The young, the elderly, people with underlying medical illnesses are at greater risk, but anybody, young adults, middle-aged adults can get this as well. There are an estimated roughly 20 million cases per year in the United States, but many, many more worldwide. And this is rarely a fatal disease, which is fortunate, but it is a major problem. And there have been major outbreaks on cruise lines in the past that have really shut down some ships. And so this is something cruise lines now pay a lot of attention to try and control. It has other names: stomach bug, stomach flu. There's no specific antiviral for norovirus. And really hydration and maybe anti-nausea medications are about all that we have to help. There is a lot of work developing a vaccine for this, and so hopefully in a few years we may have a vaccine for prevention of norovirus. Next, please. So next is rotavirus, and rotavirus is again, highly contagious. It's spread mainly person to person, not too common in the United States, but even here we still have, up to 50,000 children hospitalized with this. As I mentioned, this is much more common in young children, especially in the first 2 years of life. And we do have a very effective vaccine for rotavirus, and that's been rolled out both in the United States and pretty much all high-income countries, but many low and middle-income countries. And it's really having a great benefit. It's decreasing rotavirus rates in many parts of the world. Again, this is a disease that it can be fatal because it can lead to severe dehydration, metabolic acidosis, and electrolyte abnormalities. But with proper management, it can be well controlled. Next slide, please. So C. diff. Formerly known as Clostridium difficile, now Clostridioides difficile, is a big problem primarily in the context of healthcare with people that have been recently had antibiotics, but also certain immunosuppressive anti-inflammatory chemotherapeutic agents like methotrexate, for example, increase the risk for C. difficile, but usually it's antibiotic associated. There are an estimated 500,000 cases per year in the United States, and this is challenging to treat. For years we used vancomycin and metronidazole, but metronidazole is less effective. There's actually a fun article, probably 2 decades ago, that Sherry Gorbach, who used to be at Tufts University, he's semi-retired now, but he was also the editor-in-chief for Clinical Infectious Disease. But he wrote this editorial and where he discussed Flagyl or metronidazole versus vancomycin, and he called the title of his article "Drugs for Your Mother-in-Law." And these were basically medications where the evidence for their utility wasn't that great. So now we don't use metronidazole pretty much at all for C. diff. We use vancomycin, and then the newer drug is fidaxomicin, and this actually is much better. There's a lot of people that get treated for vancomycin, then they relapse, and so then they need another course of treatment. Relapses are less common with fidaxomicin. It is more expensive, so there's a lot of antibiotic stewardship to control its use. But we really, this is a problem for which we have good treatments, and we do a lot of work in the hospital setting to try and prevent this from developing. Next, please. So Campylobacter, this is an amazing pathogen, not even really known until about 1977, partly because growing it requires culturing the bacteria at 42 degrees Celsius, as opposed to most pathogens that grow at 37. And this is responsible for about 1.5 million illnesses per year. It is found in the intestines of chickens and other poultry, beef and other farm animals. And basically, it's really either direct contact with farm animals or contamination of food products, especially dairy products, but also chicken, that can lead to human infections. But if you're handling these, like say you're preparing chicken in your home and you're not careful with washing your hands after you finish, and you touch other things in the kitchen, then this can spread around. And so cross-contamination of surfaces or other foods can very easily occur. There are other strains of Campylobacter, but most of the Campylobacter diarrhea that we see worldwide is due to Campylobacter jejuni. This can cause invasive disease. Many people have more of a watery diarrhea, but it can cause a bloody diarrhea, and even rarely it can get into the bloodstream and cause a bloodstream infection. There's here. Let's go to the next slide, please. So this is one of those diseases where if somebody has it, it doesn't always require treatment, because many people recover on their own after 3 to 5 days of symptoms. But if they have persistent symptoms, they may require hospitalization for hydration, and antibiotics may be necessary. And if antibiotics are used, then the real antibiotics of choice are either a macrolide like azithromycin or a fluoroquinolone like ciprofloxacin or levofloxacin. The problem is that fluoroquinolone resistance has been rising in many parts of the world, even to some extent in the United States. So it's really helpful to have susceptibility testing to understand what the best option is. But most people don't need treatment for it. On the other hand, this is a disease that can lead to various complications. Post-diarrhea reactive arthritis, Guillain-Barré syndrome, which is an ascending paralysis that can be potentially life-threatening, strong association with Campylobacter, and then some less common complications are listed there. In a patient who's really immunocompromised, there's a risk that this can spread into the bloodstream and cause a bacteremia. It's pretty rare, but that can lead to a very serious infection. And then underlying immunoglobulin deficiency makes this a much harder disease to treat and can lead to relapsing infections. Next, please. So Salmonella, this is an amazing sort of category of agents. So Salmonella today are really classified. Most of the species that cause human disease are due to Salmonella enterica, and then serotypes or serovars of those. So the full name would be, say for Salmonella typhi, is Salmonella enterica serovar typhi, which we just short to S. typhi. S. typhi and S. paratyphi are invasive pathogens that are not considered causes of diarrhea, because they tend to get through the lining of the intestine into the bloodstream and cause a bacteremic illness known as enteric fever or typhoid or paratyphoid fever. But there are a whole range of other non-typhoidal Salmonella that include Salmonella typhimurium, Salmonella enteritidis, Salmonella Newport, Salmonella Dublin. There's a whole bunch of them. Some of those are some of the more common ones we encounter in the United States. They're often causes of foodborne illness. In fact, the second most common cause. And complicated disease. These are again something that humans can carry it and shed it, but also many warm-blooded animals can. And so there's a very large zoonotic reservoir for this disease. Next slide, please. Next slide has a little more information on Salmonella. So this is, again, typical for a diarrheal disease if it's not complicated, lasting around 3 to 5 or 4 to 7 days. Dehydration may result, as well as metabolic complications, but that's much more likely in really young children and older adults. This is another bacterial pathogen that may be followed, infection may be followed by the development of reactive arthritis, a few weeks after infection or even a few months. The challenge with this is that in certain patients, especially older patients or really young, or those who are immunocompromised, they may end up with salmonella getting into their bloodstream, bacteremia, and then that can lead to seeding of the meninges, and so therefore a bacterial meningitis can get into the bones, into joints, leading to osteomyelitis and septic arthritis, and it can even lead to infections of prosthetic devices. So really a major challenge, and treatable. And there are many good antibiotics that work against this, especially fluoroquinolones and azithromycin or third-generation cephalosporins, but something that we try and control as much as possible. Next, please. So Shigella, this is another bacterial pathogen. This causes a syndrome called shigellosis. This is generally a cause of invasive diarrhea. I mean, sometimes it can cause a fairly high volume watery diarrhea, but most of the time it causes small volume bloody bowel movements, bloody or purulent. And so it really causes an inflammatory invasive diarrhea. This is primarily found in humans, so it's more common of spread person to person through a fecal oral route. With either direct person-to-person contact or contamination of food. And there are certain risk factors, including severe undernutrition, that may increase risk, especially in young children, but in older adults as well. And then there are 4 major species of Shigella. Of those, Shigella dysenteriae type 01 it can cause a much more severe disease with a number of complications including systemic complications. Next, please. So this presents with, generally with small volume but frequent bowel movements, often containing mucus, pus, and blood. It can lead to basically a straining that can lead to loss of control of the feces, so fecal incontinence. And then, if you do like a flexible sigmoidoscopy, there's all this inflammation and ulcerations of the colonic mucosa. This may resolve on its own in 4 to 8 days, although generally most practitioners, including the CDC and the World Health Organization, recommend treatment of Shigella with antibiotics. And again, there's a range of antibiotics, but the fluoroquinolones and azithromycin are sort of high on the list because resistance is developed to many other classes. Young children, this can lead to a fairly profound complications with severe weight loss and dehydration if it's not treated. And one of the challenges that we've seen very recently, in fact, in the United States, in February, the CDC announced that they're seeing an XDR, so extensively drug-resistant Shigella infections, resistant to all sort of the common antibiotics plus fluoroquinolones, and sometimes even to third-generation cephalosporins. And these become very difficult to treat. Next, please. So cholera. Cholera is caused by Vibrio cholera. This is usually found either in water or foods. And it has to be very heavily contaminated in water. The inoculum, I'm going to contrast this to Shigella. The inoculum for Shigella is as little as 10 bacteria, 10 to 100 bacteria, and then you can become sick. And Shigella is to a certain extent acid resistant. So the normal acidity of the stomach it can survive that, get into the intestine, cause infection. Vibrio cholera, it's acid susceptible. So if you have normal gastric acidity, it really kills off a lot of the cholera, unless there's just large volume, like 10,000, 100,000, or 1 million bacteria per milliliter in very heavily contaminated water. Then infection may occur. Symptoms: main symptom is watery diarrhea. There may be vomiting as well, And this can be massive watery diarrhea. The cholera toxin leads to an activation of chloride secretion, and this leads to unrestricted water loss, and you can end up with 10, 20 or more liters of stool output per day. And this woman on the right is actually on a cholera cot in Bangladesh. We have permission to use this. I've used this actually picture several times in textbook chapters, but if you see her abdomen, you can see how there's like a little ridge there. She has tenting because they've pinched her mucosa and it's not folding back in place. That means she has significantly reduced turgor. She's severely dehydrated. And so that's one of the complications, is severe dehydration. This leads to a diarrhea that looks like rice water. It looks like you've taken sort of a slurry of rice and mixed it with water, so it's sort of cloudy with little small pellets of rice-like particles in it. So you can often make the diagnosis clinically just based on the severe diarrhea, the dehydration, and the appearance of the stool. It may lead to complications because of dehydration with hypotension, a weak pulse, and reduced urine output. And if this is not treated, it can lead to shock and death. Next slide, please. So just on cholera, just to further comment. I mean, with milder cases, we use oral rehydration. With severe dehydration, we'll use intravenous, and then antibiotics as an adjunct help accelerate the clearance of the bacteria faster. So let me shift and talk about a really cool parasite, not one that's fun to have, but really just interesting. This is Giardia lamblia, also known as Giardia intestinalis, sometimes Giardia duodenalis. This is one of the most common waterborne disease outbreak causes in the United States, along with cryptosporidium, which I'll talk about in a minute. This can be found in streams and lakes, but also in public water supplies. Sometimes wells may become contaminated, and then swimming pools. The Giardia cysts are relatively resistant to chlorine, and that facilitates transmission even in the context of chlorinated water. So really filtration is needed to remove this from the water system. This is a global disease. It's found all over the world, and so prevalence studies show that a lot of people carry this. Once you've had a symptomatic episode, you can be exposed to it later, and usually your immunity from the prior episode leads to your becoming infected and shedding it, but not having symptoms. And this also, there are a few, sort of handful of antiparasitic drugs that are effective for treating this. Next, please. So broadly, this is a description of some of the clinical syndromes associated with intestinal parasites. Maybe we should have had this before Giardia, but that's okay. So on the watery diarrhea side, Giardia is one of the common players, and then Cryptosporidium, Cyclospora, and Cysticercospora. Microsporidium are much rarer, and these are usually associated with infections in immunocompromised individuals, especially AIDS patients. On the bloody diarrhea side, there are a number of pathogens, especially Entamoeba histolytica, that can cause a dysentery-like syndrome, but this can also occur from Balantidium coli, from a very heavy infection with the whipworm Trichuris, as well as schistosomiasis and strongyloidiasis, but less commonly. And just in terms of Cryptosporidium, this is the leading cause, or one of the leading causes. I mean, it's, it depends on the year. It's either Giardia or Cryptosporidium, but I think generally in recent years, Cryptosporidium has led the list of waterborne outbreaks in the United States, but it's also commonly associated with animal contact. Next, please. So let me shift and talk a little bit about testing. So why is it important to test? Well, I mean, I'm an infectious disease specialist and an epidemiologist. From the epidemiology standpoint, it's important to understand, what are the major causes and what's the evolution and changes, but also be able to identify outbreaks. Worldwide, gastrointestinal infections are the second most common infectious disease worldwide after respiratory problems. And estimates of more than 350 million Americans are affected each year with acute gastroenteritis. More than 300 children die, probably a greater total number of deaths if we include adults. And then you see the numbers, more than 100,000 hospitalizations, 900 deaths from norovirus. For salmonella, over 26,000 hospitalizations, 400 deaths. And basically an estimated 3,000 people in the US die from foodborne illness each year. So all this leads to massive expense, and you can see that over $135 billion of estimated total expenses for healthcare in the U.S. related to gastrointestinal disease. And the thing is, we have a number of good tests, and in recent years we have even better tests to identify the etiology. And this becomes important both to know what the cause of an outbreak is, to do outbreak investigations, but also on the individual patient basis, what do they have? Is it bacterial? Is it an invasive diarrhea that needs antibiotics? What is the antibiotic susceptibility pattern? Or is this something like norovirus where we have no treatments, but we need to know that there might be an outbreak, or there's a risk for an outbreak in the home, so family members need to know. But it leads to differences in management and in response. Next slide, please. So there are a number of different specimens that can be sampled for testing. Generally, stool is the most common of these, but actually vomit, emesis can be used, especially in outbreak investigations. And then serum for serologic studies can be helpful. And then in outbreaks, in the CDC, and usually they work closely with the Food and Drug Administration. If it's a foodborne outbreak, they have a whole process to try and identify the vehicles. They'll do like a case control study, figure out what food was associated with the outbreak, and then they look at, was it a food produced in one place? If so, they can trace it back to the producer, and they may then go and inspect the farm where the food was produced and see if there are any abnormalities or contamination of the environment there, or some deficiency in the food production and processing sort of output. So those other sort of surfaces and food and water samples are done much more commonly for food outbreaks, but clinically it's really feces are the main source of samples. Next, please. So there are a number of different approaches. I'm actually going to start with the middle. So culture has really been one of the mainstays for diagnosis. So basically, there's specialized culture media for certain pathogens, but many will grow on more typical media. But then some require more specialized setups, like Campylobacter, where it has to grow at 42 degrees. Culture is great because you grow the bacteria. You can then do susceptibility testing, which becomes very important for certain pathogens. But it can take 2 or 3 days, or even a little bit longer in some cases. There are antigen tests for certain pathogens. There are ELISAs for norovirus. There are antigen tests for Giardia and Cryptosporidium. These are pretty sensitive and pretty good tests, and they can give a fairly rapid turnaround time, but not so useful for many of the bacterias that we worry about that can cause outbreaks of diarrheal disease. And then there are molecular tests. So usually using a polymerase chain reaction, and these are great. They have a shorter turnaround time depending on the capacity of the lab and really the staffing of the laboratory. And we'll talk more about those. There are a number of sort of panels that have been developed, gastrointestinal panels, that are really helpful to me and people like me as a practitioner to understand what the cause of an individual's diarrhea is, and also to get an answer more rapidly. I've already mentioned antibiotic resistance. That becomes important for bacterial pathogens. And then microscopy can be done to really identify ova and parasites for both protozoal pathogens and helminth or worms. It also can be done to see how much inflammation is there, to see if there are fecal leukocytes present, to see if this is inflammatory versus non-inflammatory diarrhea. Next, please. So I've already mentioned that stool cultures take time. They're very useful, but they can be 1 to 3 days to turn around, and they do require a little bit more work. Although sometimes it's automated these days, it requires culturing and sometimes subculturing, then identification of the pathogen, and then if it's a pathogen for which antibiotics are necessary, then antibiotic susceptibility testing becomes important. Contamination in the sample collection or lack of a controlled environment can lead to problems with both false positives and false negatives, but also if there's been preceding antibiotic use, that may make it hard to culture an organism, and therefore it's more challenging. And then with traditional stool culture, it misses a lot of Campylobacter infections because this requires both special media and a different temperature. So it can be a bit more challenging. Next, please. So molecular testing. So this is really a fantastic revolution. It's so much has happened in the last, especially the last 10 years, but it's really the last 10 to 15 years. But it just amazes me how many hospitals now have multiplex assays available to test for diarrheal pathogens. These have short turnaround time, and there are different platforms. Some will test for pretty much all major bacterial, viral, and protozoal pathogens in one panel. Others will break it up into bacterial, viral, and protozoal. It depends on which company's making it. But basically, these are very useful because of the short turnaround time, and they're highly sensitive with great specificity, and you can look for multiple pathogens using the same sample. And one notable outcome is that we'll often identify that there's a co-infection, that there's more than one organism present that may be responsible for the diarrhea. And then it becomes up to the clinician to try and figure out which is key, or more than one pathogen is really responsible. Next, please. So this is just showing the molecular panel formats. As I mentioned, that there's some formats that cover, I think there's one that has, 22 different targets on it, including viruses, bacteria, and parasites. This is usually used in inpatient scenarios, but I'm one of my areas of specialization is travel medicine, and some of my colleagues that have busy travel medicine practices will have their own machines to do multiplex PCR in their offices to be able to make a fairly quick decision about what they have and whether it requires antibiotics versus just hydration alone. And these become important, because the great sensitivity, if they identify certain pathogens, then those data usually feed back to the state or city Department of Public Health. And if an individual is in the food service industry and they're identified with certain pathogens, then the state reaches out to them to basically tell them they can't work until they've cleared this infection. So there's sort of a whole process in terms of feeding these results back. You can see this broad array of pathogens here. It's just amazing, like how many different organisms you can test for in one sample. Again, this is for a multiplex broad panel. There are some companies that have broken this down into bacterial, viral, and parasitic. And then if somebody's not sure, they order all three. But if they think it's likely to be like chronic diarrhea, they might just order the parasitic panel. Next, please. So here, this is getting into the different panels. So looking at, you can see that there's a bacterial panel, viral, and parasitic. And these might be a little more cost effective because they may be a little less expensive than looking for like 20 plus pathogens all at once, running a more narrow spectrum panel. And these are maybe better in terms of reimbursement as well. I think that there's definitely a lot of value to these. And again, the biggest value, at least from the perspective of a clinician, is the turnaround time is very short. Next, please. So this is just a little bit about sort of, circumstances. If you have persistent diarrhea, you have, then you're going to be thinking of certain kinds of pathogens, or if you have an immunocompromised host, that individual may be shedding and have symptoms for a lot longer. Hospitalized patients are at greater risk for severity. And really all these are sort of high risk situations that can be associated with a greater risk of complications, but also potentially death. And so here it's really important to be able to identify the pathogen as quickly as possible. So if a specific treatment is available, that can be used. Next, please. So this looks at different situations. So with bloody diarrhea, generally a bacterial panel will be useful, although I would say also that the parasitic panel, if you're worried about potentially Entamoeba histolytica, that could be used there. If there's a new known foodborne outbreak, then the bacterial and viral pathogen, viral panels would be necessary. Travel is sort of the #1 cause of travel-related disease is enterotoxigenic E. coli, enteroaggregative E. coli, followed by Shigella, Salmonella, and Campylobacter, but maybe 5 to 10% of travelers will have Giardia or Cryptosporidium. So there, both bacterial and parasitic are important, but often travelers will develop norovirus as well. So all three panels may be necessary. And again, with these more narrow spectrum panels, these allow a more targeted the testing and decision making, based on what the clinical suspicion is. Next, please. Okay, so this is a patient I saw a couple years ago, and the picture on the right is the Taj Mahal at sunrise. Actually, a picture I took when I was in Agra a couple years ago. Really amazing, beautiful place, worth visiting. So we had a woman who had been on the same trip. She was 40 years old. She presented with diarrhea. She had non-bloody bowel movements 3 to 5 times per day, with nausea, fatigue, and abdominal pain. And it started about 3 days after she came back from India. So, within the incubation period for typical bacterial pathogens, a little bit, usually it's 1 to 4 days or thereabouts. It fits. We, suspected she had traveler's diarrhea, which sometimes in India is known as Delhi belly. We sent a multiplex panel, and this included really both, bacterial, viral, and protozoal, and it came back as norovirus. And we said, wow, that's weird, because norovirus has a pretty short incubation period, and so sort of thought about it a little bit, and then it turns out we asked her some more questions, and she'd been to a family gathering the day after she came back to the United States, and several family members she now knew had developed acute gastroenteritis with a lot of nausea, vomiting, and some diarrhea. So there'd probably been a cluster of a focal outbreak of norovirus that she was exposed to after travel, and this had nothing to do with her trip to India. So this just shows, one example of how the testing can be used, and sometimes leads to some surprise results. I mean, I have colleagues that have had some really interesting stories they've told me about, surprises they've had, through the use of molecular testing. Next, please. I think it's important to note, though, that molecular testing is not perfect, and this is going to help you identify, usually the DNA of bacteria or RNA of viruses, and it doesn't tell you that there's an active infection, although if there's ongoing symptoms and you have a specific cause, then that's pretty, makes sense to put the two together. But the challenge is, for bacterial pathogens, it does not give you antibiotic susceptibility. And so many hospitals now will have a reflex where if they identify, say, Campylobacter, Salmonella, or Shigella, then they will have saved some of the initial stool sample, and then they can culture it. And so they won't do the stool culture unless there's a need to, but then they can then try and culture it and hopefully grow the organism and have susceptibility data for the clinicians managing the patient. And I think, the other sort of challenge with this is that these assays are really highly sensitive. I think the specificity is excellent, but I do know, I mean, I've seen this a few times, and I have colleagues who end up with 4 or 5 different positives from a single sample. And then the question is, which of these, which is like colonizing the intestine versus causing actual infection, and that requires, some clinical judgment. Next, please. I think that's it. So I think we're ready for questions and answers, and I thank you for the attention, and I'm happy to take any questions.
Yes, thank you. Give me one moment. Our first question, Dr. Hamer, is what is the role of useful bacterial flora to control GI infections?
Okay. Well, so the use of, and basically, of gastrointestinal flora has been largely limited to I'd say a supplemental treatment for refractory or recurrent C. difficile infection. And their, sort of replacement of some of the abnormal bowel flora with normal flora from another person. And now, there's a lot of ways to sort of regulate the balance of that to try and make sure no pathogens are being transmitted. It is really a treatment for, really severe relapsing C. difficile or C. difficile that's been refractory to typical treatment. But beyond that, there really is not a role for all the other pathogens that I've mentioned.
Okay. Now, here's another. This is a general one. What are the first GI pathogens to test?
That really depends on the context. I mean, I think it depends a little bit on the clinical presentation, although there's so much overlap, it can be hard to distinguish between syndromes. But if you have somebody presenting mainly with nausea, vomiting, a little bit of diarrhea, you're going to start thinking about viruses, especially norovirus. If you have somebody with young children in the home and the children are having diarrhea, you might have rotavirus. If you have somebody that has had exposure to potato salad that's been left out at room temperature for hours, they might have a toxin-mediated food poisoning, and we don't really have good assays for those. Somebody who's recently traveled and comes back with bloody diarrhea, you're going to think about Shigella. So it really depends on the context, and then the underlying, the host as well. What sort of underlying disease do they have that might predispose them? So it takes a little bit of decision making from the clinician to sort of target the diagnostic workup. Although, with the multiplex panels that have 20 plus pathogens on them, that makes it a little bit easier, but those may not always be cost effective to use for every patient.
Okay. Here's another question. Can you address C. diff in a multiplex PCR assay? Should C. diff be included in the panel for several reasons? And cannot the person further comments that they cannot tell if a liquid stool, would like to hear your opinion on addressing C. diff in a multiplex PCR assay. I'll leave it at that.
Yeah, no, that's a good question. It's funny because I just did a tour of a microbiology lab. I'm visiting the University of Oklahoma, and we were talking about just that question because they would rather have people order the specific C. difficile test. And one of the multiplex tests includes C. difficile in the panel. Not all bacterial panels have C. difficile. The sensitivity may be a little bit lower, but also, if you identify it, some people will be harboring C. diff and be asymptomatic, and so it becomes a little bit of a challenge. If they have some other cause, you probably want to treat the other cause, but if that involves antibiotic treatment, then you're going to be worried about exacerbating the C. diff. And I think many hospitals would rather use a test that's independently targeting C. diff rather than C. diff on a panel. But if it is present on the panel and positive, then I think it becomes important information to feed back to clinicians so they're aware, even if that was not something they were looking for. But that's a tough question. That really becomes a decision-making process with the microbiology laboratory and often infection control as to how they want to organize C. difficile testing in their hospital.
Okay. Here's another. Do you see a future where molecular diagnostics can completely replace culture and sensitivity testing for bacterial infections?
Yes, potentially. I mean, I think we would need we need to understand all the molecular targets for specific that lead to specific types of resistance. And the problem is there's so many different types depending on the bacteria that you might have to add a lot of special targets. I think it's sort of feasible in theory, but in practice, it's going to require both understanding all the mechanisms of um, and really genetic targets that are lead to resistance, and then being able to add those to a multiplex PCR to detect them. So it's I think it's feasible, but I think we're years away from that. So I think we're still going to be stuck with doing reflex culture and susceptibility testing on actual isolates.
Dr. Hamer, thank you so much. As I said, we know you're on the road and need to get going here. And thank you to Thermo Fisher Scientific for sponsoring this event. We'll continue watching diagnostics in this area, so stay tuned.